Moving on to session 6, we are having an online session, Millennium Lecture by Padma Shri Dr. M.R. Rajagopal. To chair this session, I request Dr. O.P. Sharma, Honorary General Secretary of GSI, and Dr. K. Hari, Chairperson GSI Kerala, to please come onto the stage.
Recording in progress.
So good afternoon. Dr. M.R. Rajagopal is going to have a video talk right now. As you are aware that he was planning to come because of some issues. He dropped the idea of traveling, and he needs to be introduced by Dr. Sharma sir.
When we were doing conference at Kerala, Dr. Sajesh said that there are two very, very senior physicians from Kerala who deserve respect on all forums. One of them is Professor K.P. Paulos and other is Dr. M.R. Rajagopal. Dr. Rajagopal was unable to come, but then he agreed to give it online talk. Professor Rajagopal, we had no other choice except to think of something equivalent and a big name. And for the first time in the history of Geriatrics Society of India, we have created this lecture which is called Millennium Lecture. Give a big hand to Dr. M.R. Rajagopal for delivering Millennium Lecture. Born on 23rd September 1947, a renowned Indian palliative care physician and an anesthetist. Actually, the word terminal care doesn't look good actually. We had a lot of discussions with Dr. Lingegoda on this issue, that let's call it something different. And the name palliative care came and it became very popular. He is referred as father of the palliative care in India. His significant contributions have transformed the landscape of palliative care in the country, earned him widespread recognition and respect. Dr. Rajagopal currently serves as Chairman Emeritus of Palliative India, an organization dedicated to improving palliative care access and services. He is also an adjunct professor of global oncology at Queen's University, Canada. In addition to his clinical and academic roles, Dr. Rajagopal is the author of the insight book, Walk with the Weary, which reflects his dedication to compassionate care for the terminally ill people. His work has profoundly impacted the lives of many, setting a benchmark for palliative care globally and cementing his legacy as a pioneer in this vital field. Over to you, Professor Rajagopal sir, for your talk. Rajesh, let the talk begin. Welcome, sir. Namaskaram, namaskaram. Whole Geriatric Society of India does namaskar to you and requests you to give your presentation. Sir.
Professional interest, but deeply personal interest to me. I'm glad you people are there. At my age, you are very important to me. I therefore talk to you not only as a palliative care professional, but also as your potential patient. So I am going to try to tell you what I really want when I come to you when my time comes with an illness. Let me share my screen and then share a few thoughts with you. I'm going to talk about this business of integrating palliative care into your geriatric practice. Not only because 2/3 of the patients that we see in Trivandrum are elderly, but also because uh, this cannot be done by palliative care physicians. This will mostly be done by every geriatrician also. Uh, but as your patient, let me remind you, healthcare is my right. Your duty to me is defined by officially by a statutory body of Government of India, the Indian Council of Medical Research, as to mitigate my suffering, to cure sometimes. Ordinarily, anyway, only about 1/3 of all diseases are curable. But at my age, that percentage would be even smaller. But if possible, please cure me. If not, relieve my symptoms and treat my disease so as to help me to live with the disease as well as possible, and at the same time to comfort me. You know that at my age, emotions are more level, and I hope you will be there with compassion in your eyes and in the hand that I hope you will touch me with. Please remember that last sentence. In your duty of care as defined by ICMR, it's clearly said there are no exceptions to this principle. I hope you will grant me this request. I'll also remind you that as healthcare, we know this definition. It is not, health is not only absence of disease or infirmity, it is physical, social, and mental well-being. I requested you to give me health care and to relieve my suffering. I am also requesting you to look after my physical, social, and mental well-being. What I mean by that, I will come to a bit more details. For example, pain. I unfortunately very often find that pain is okay. Anyway, pain is not treated in our country. The estimates show that only about 4% of people across the country have access to decent pain relief. But when you are talking about the elderly, it becomes even less likely because you are careful about my kidney, about my heart, about my organs. It's very likely that I will be refused pain relief, meaningful pain relief. This is the WHO 3-step analgesic ladder. Step 1, step 2, and step 3. This is designed for cancer pain, but with adaptation, same principles apply for any treatment of any pain. In the first step, you have non-opioids, and adjuvants are medicines which contribute to pain relief, which are not basically painkillers like tricyclics or anticonvulsants for neuropathic pain, like corticosteroid for a nerve compression pain, uh, and so on. Now, I cannot possibly cover this in detail in today's session, but I'll talk about pain a little bit, only a little bit, because that will illustrate how the management differs between palliative care, that is a person-centered approach, and an organ and body-centered approach. Let us take the case of our humble paracetamol, which we all take for granted. Your practice in most areas will be evidence-based. But when it comes to paracetamol, we seem to be most of the time superstitious. I know you may not be able to give me many painkillers or a pain relief center or palliative care center may not be available easily. But what is often forgotten is the dose and the frequency. Almost every prescription you will say paracetamol, or rather by a trade name, 1 tablet TID or 111. Simply inadequate. How can it be? It does not have any reasonable effect for more than 6 hours. It needs to be given 4 times a day. Thank you very much. Please give that to me. At least in dose of 12 milligram per kg. I am only 51 kg. But please remember that a 500 milligram tablet will not be enough for any significant pain relief for me. I will need 650 milligram tablet. Up to 50 milligram per kg is quite okay. And about your concern, of course, it does not cause any renal dysfunction or cardiac dysfunction. But if you are worried about my liver, see, we have evidence that even in the presence of chronic liver disease like cirrhosis, a dose of 2 to 3 grams per day is okay. That falls within the dose I mentioned. And I'm also worried that you may not take the tablet seriously and may give me intravenous infusion. For one thing, you will not be able to continue it for long enough. But the other point, I'm not a rich man. How much does it cost? Oh my God. When I leave this world, I don't want to leave my wife and children paupers. Please remember, health is physical, social, and mental well-being. Remember that you can cause destruction of my family members' health by the cost of treatment. 55 million Indians every year are driven below poverty line by catastrophic health expenditure. India is among the worst 12 countries where this happens. See, on this axis there is pain and here time. The pain relief is not so hugely different anyway. And over some time, it turns out to be almost similar. Oral paracetamol has good bioavailability. So long as I am able to have the tablets, please resort to oral paracetamol. And if we talk about other non-steroidal anti-inflammatory drugs, I know you will be careful about my kidney. You know that as an old man, my kidneys will be more vulnerable than a young person. Having said that, you know what are the possibilities. I also know that you will be worried about my kidneys, by your stomach. But protect my stomach with a proton pump inhibitor early in the morning on empty stomach. And kidney, if I have a problem, after all, how many choices do we have? If I have serious musculoskeletal pain, making me unable to even move, I see this. I see people, elderly people, whether rich or poor, in their beds, in fetal position, with contractures over every joint, because they are not able to tolerate the pain of a single movement, and eventually this happens, and without any reasonable pain relief. Especially in joint and musculoskeletal pains, opioids also will be more or less ineffective adequately. So your Ultraset also may not help. Your paracetamol will be inadequate. Sometimes NSAIDs are necessary. I am not saying that you should consider that as a first step, but if nothing else works, please do not leave me in pain so that I end up in a fetal position with horrendous pressure sores on both sides. Protect my kidney. If nothing else works, limit the dose. I'll tell you the dose. But according to current available evidence, please choose ibuprofen or naproxen, because all other NSAIDs seem to be, as far as we know, seem to be causing significant cardiovascular or cerebral events, including diclofenac, and particularly bad with coccyx. Just limit the dose, ensure adequate fluid intake, and please avoid the COX-2 selective medicine, very clearly shown to be causing 5 times more of cerebral or cardiovascular events. You give me ibuprofen, limit it to 400 milligram TAD. More than that would not be wise. But with this, let me have some physiotherapy. Without this, it will not be possible. I will end up with contractures and a horrendous life. This, I have given the reference there. Anybody is free to have this presentation for the references. This is a study which revolutionized the use of NSAIDs across the world, involving the whole population of Denmark over a 10-year period, and they showed that coccyx and diclofenac increase the chance, I repeat, of cardiovascular and cerebral events by as many as 5 times. And how about opioids? For non-cancer pains, can you use opioids? Not as a first-line drug, not as a second-line drug, but as a third-line drug. Please use it if nothing else relieves my pain. Precautions are necessary. Clear understanding with the person and family. You will prescribe the dose and I will limit it to it. But you will have to remember that the dose is appropriate. Sometimes one TAD doesn't work. The dose requirement of opioids, unlike most of the medicines, depends on the degree of pain. The understanding is that there will be no unsanctioned dose escalations. And most important, more than this remote possibility of addiction, is the possibility of bowel ill health, say constipation. That can kill. So, this is my request. In your practice, both in routine and in end of life particularly, please look after my well-being and symptom control. I have some more things to say about end of life care. This is one of my greatest fears. My greatest fears is that in my last weeks, I will be shut up in a prison. Dr. Sankha Mitra is a British oncologist who does charity work in the Northeast, and he is appalled to see the situation in our country, where he says the poor die in misery of neglect, the middle class die in misery and ignorance, and the rich die in misery on ventilators. No one gets a pain-free and dignified death. Maybe a bit of exaggeration, but not much. You can get a pain-free and dignified death only if you stay at home and you get some medical support at home. Dr. Sanghamitra, he said it's British oncologist. That's why he is so appalled. India is among the worst countries for end-of-life care. Among global countries, according to a Lion Foundation study, it's among the worst 1/4 of countries. See, these are data that you can access. Both are open access papers that I have quoted here. The first panel on the left is from European Union countries, where they found that among people in ICU, once treatment is considered futile by the treating doctors after more than one doctor, then with the concurrence of the families, around 90% of them, 89.6% of them, are taken off life support systems, ventilators or ECMO or whatever. Instead given palliative care, then they are allowed to die with dignity. They have so much more resources than our country, and there this happens. Compare that with what happens in India. This is also recent, 2021, by Rajkumar Mani, the well-known geriatrician, perhaps the most, no, sorry, intensive care physician, the best-known intensive care physician, a man of great, very, very upright and great integrity. And he's found this study, in this study, that approximately 70% of people on life support systems, even when treatment is considered futile, die on their life support systems. Of all the deaths, 70%. Only 30% come off and they don't get palliative care either. They are subjected to very inhumane and unethical ending. Frightening. This is not about them, this is about us. Now, look, I have been moaning about problems. Let me come to the positive. Thankfully, there is some legal clarity now. I have written my advance directive. I have got it countersigned by a gazetted officer. I have said that in such and such situations, I should not be subjected to artificial life support measures. And ladies and gentlemen, since last year, this is legally valid. Once I have got it countersigned by a gazetted officer, it's binding on you. I have got the permission and concurrence, total concurrence from my wife and children. I have even appointed a fourth relative as my attorney in case my own family is not available to take care of these decisions when I am no longer able to make my own decisions. This is binding on you, but I cannot go to court after I am dead unless you. Please read that article for which I have given reference. It's not a very complicated thing. Please respect my advanced medical directives. According to this, if I turn out to be in hospital, I have some difficulties. I had better stay at home. Please, doctors, help me to stay at home and give me some care. If you are in a hospital and already on intensive care, then a medical board within the hospital will have to meet. I suppose if you are kind, it will happen within hours. But the court says the decision within 2 days. Then the district second medical board appointed with the DMO will have to meet again. That may take time. The court says preferably in 2 days. I don't know how long will it take. During that time, those several days, what will be happening to me? A tube in every orifice. A suction catheter goes through my intensive care, by my tracheostomy or endotracheal tube, which is already feeling like a red hot iron, and going through and being twisted as it is drawn. People who have experienced have described to me how dreadful, how cruel that is. I was an intensive care doctor. I have done this. I know its value. I know it can miraculously save lives. Even at this age, if I have a fracture of 6 ribs, I want intensive care to save me. But not in the context of a futile treatment. I would really like you to look at those documents regarding end-of-life care and current legal status. Very often lack of awareness, the ignorance is the problem for creation of problem. Because the court has done this, we, the people who are closer to death than most of you, have some hope. Only if you respect my advanced medical directives. I hope you will all learn some palliative care. The World Health Assembly in 2014 passed a resolution asking all member countries, including India, to integrate palliative care into all health care, naturally, including geriatric care. And this cannot be done only in palliative care units, it has to be done in your practice. Our courses are there, including a self-paced online course which you can do at your own time. And about the advanced directives, including a sample for the advanced directive. Doctors, we are all mortal. Please give this some thought. The form and end-of-life care policies also, they are available on our website. I would really request to give this attention. I request also the organizers to share this with the registrants, if at all possible for you, so that that will be available for reference. I stop with that. I thank you once again for this invitation and for listening to me so patiently. Thank you very much.
Sir, thank you so much for your words of wisdom. People know your dedication towards palliative care, and I think the three things that bring the patient to the doctor is pain, bleeding, and obstruction. Pain is one of the important component, and when you feel helpless that nothing can be done, as a medico, you really feel pain yourself, and you want to take out the pain of the patient as much as you can. Thank you for telling us about the safe drugs, certain guidelines. We are grateful to you, and on behalf of Geriatric Society of India, on behalf of Kerala branch of GSI, on behalf of GSICON 2024, on behalf of IMA, and on behalf of API Kerala chapter, we profoundly thank you and we are grateful to you. Thank you so much, sir.
Thank you. Thank you, sir. And thank you, everyone.
Dr. Sajesh? Dr. Sajesh?
I request Dr. O.P. Sharma and Dr. Hari to remain on the stage. And I request Dr. O.P. Sharma to receive the memento for the Millennium Lecture on behalf of Dr. M.R. Rajagopal. And I request Dr. K. Hari to hand over the same.
I will agree to the organizers this request. I would also agree to their request if they say that we'll pay you for the airfare, you go and deliver it at Canada. Thank you, sir. Namaskaram.
Thank you.
Okay, sir. All the best to you, sir. You regain your good health, please. Okay.
Thank you. Thank you.